Welcome to the Technical Assistance Network for Children's Behavioral Health, Cultural and Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a webinar or monthly call with topics focusing on culture, health equity, and disparities in children's behavioral health. Topics are generated by you, individuals working in or being served by behavioral health organizations and partnering with system of care states and communities. The TA Network, as it is known, is the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration, or SAMHSA. Today's webinar is part 4 of a 4-part series on implementing the National Standards for Culturally and Linguistically Appropriate Services, also known as the CLAS Standards. Today's webinar centers on leadership and cultural and linguistic competence under the CLAS Standards. My name is Catalina Booth, and I am the Executive Director of the Center for Community Learning. As a partner in the TA Network, the Center for Community Learning provides technical assistance in the area of cultural and linguistic competence. Our expertise focuses around issues of language assistance, class standard implementation, community capacity building, diversity and equity training, behavioral health literacy, and reducing behavioral health disparities. Today's webinar and discussion will be led by Selena Webster-Bass and Linda Callejas. Linda Callejas, who's a research assistant professor at the Department of Child and Family Services of the College of Behavioral and Community Science at the University of South Florida, unfortunately will not be with us today as she is in the process of evacuating for Hurricane Irma. However, we do have Selena with us today. Selena holds a Master's of Public Health. She's a native of Jacksonville, Florida. She has served as a health advocate for over 15 years in promoting the national CLAS standards within primary and behavioral health organizations. While serving under the Jacksonville System of Care Initiative, Substance Abuse and Mental Health Services Administration Implementation and Expansion Grant, Selena worked as a cultural and linguistic competency educator for over 5 years. In this role, she facilitated professional, family, and youth CLC training and development, conducted CLC organizational self-assessment, integrated system of care core values and wraparound care coordination, and promoted multicultural community engagement. Selena's background is in public health, cultural and linguistic competency, behavioral health, urban health, and faith-based engagement. She is certified in adult and youth mental health first aid, and she works with various community organizations promoting mental health literacy. Selena is currently the CEO of the Voices Institute, a consulting group focused on multicultural consciousness, equity, and well-being. She is a core partner with the Technical Assistance Network for Children's Behavioral Health and the National Training and Technical Assistance Center for Children's Behavioral Health, Cultural and Linguistic Competency Team. This presentation is being recorded. Your lines will be muted right now to help eliminate background noise, so feel free to use the chat box to type in any questions or comments during the presentation. Following our presentation, we'll open the lines for further questions and discussion. So without further ado, let's get started.
Thank you so much for that introduction, Catalina. Good afternoon to all of our participants. We're so glad that you joined us today. So for today's webinar, we will provide an overview of the National Culturally and Linguistically Appropriate Services Standards in Health and Healthcare, and we will also address specific standards related to cultural responsiveness and leadership, governance, and workforce development. I will use John Kotter's change model as a framework to describe approaches to organizational cultural responsiveness and leadership, and also list some leadership strategies to advance organizational cultural responsiveness within behavioral health organizations. The National Enhanced Standards for Culturally and Linguistically Appropriate Services, or CLAS standards, are a set of 15 action steps intended to advance health equity, improve quality, and help eliminate behavioral health care disparities. These action steps provide a blueprint for individuals and healthcare organizations to implement culturally and linguistically appropriate services with youth, children, and families. The original CLAS standards were published in 2000 by the U.S. Department of Health and Human Services Office of Minority Health The updated or enhanced 2013 National CLAS Standards expanded the definition of culture and health, broadened the audience to include primary care, behavioral health, specialty clinics, academic centers, community-based organizations, and also changed the language from patients and clients to individuals and groups. The 2013 Enhanced Standards are a blueprint for sustaining cultural and linguistic practice and policy. And these standards are just a starting point for delivering culturally and linguistically responsive services and our recommendations and mandates that are given by the federal government. The Principal CLAS Standard provides a frame for all of the other 14 standards. If all the other standards are implemented and sustained, then Standard 1 is achieved. We like to think of the principal standard as the final outcome, the destination, the end goal in providing culturally and linguistically appropriate services to children, youth, and families. The final outcome is to provide equitable, effective, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs, practices, preferred languages, health literacy, and other communication needs. The CLAS standards are divided into 3 categories or themes. The first category is governance, leadership, and workforce development, which we will focus on today, communication and language assistance, and then the third category is continuous quality improvement and accountability. This slide shows the 3 standards that fall under the first category or theme, governance, leadership, and workforce development. Standard 2 is to advance and sustain organizational governance. This is about appropriating resources, modeling and appreciation and respect of cultural differences, and also modeling culturally responsive behaviors. The second standard is focused on recruitment and support of a diverse governance group. And the third standard is to educate and train. So it's focused on workforce development and professional learning. A culturally responsive organization infuses the national CLAS standards throughout its operations. Its governance, communication structures, and its assessment and continuous quality improvement. The implementation of the national CLAS standards requires a top-down and bottom-up approach. This approach should be systematic, comprehensive, and a concerted effort of all organizational members. It is the organizational leadership that is the thermostat of the organization. The organizational leaders regulate and activate cultural competency priorities and expectations. It is the organizational leadership that establishes the culture of the organization in delivering quality, equitable, understandable services that honor our children, youth, and families regardless of their cultural background. Sorry, my apologies. So at the macro level, a culturally responsive organization has developed congruent attitudes, behaviors, policies, processes, and structures that enable a system to work effectively in multicultural environments. So let's think about this word leadership. I'd like to hear from you and like for you to think about an adjective or attribute of an effective culturally and linguistically competent leader. So in other words, a culturally and linguistically competent leader is blank. And we'd like to create a word cloud or an image of these adjectives. So I'm going to turn the screen over to Gary, our assistant, and he's going to take us to a screen so that we can develop our word cloud. So again, we'd like you to think about an adjective or attribute of an effective culturally and linguistically competent leader. All right, so we're at our screen. And so we'd like for you to type in that adjective or attribute that you're thinking of. I see responsive, empathy, other responses? Open, absolutely. Any other responses? Genuine. Passionate, absolutely, yes. Trusting. So thank you so much for sharing your thoughts on culturally competent leadership. Go back to the slides now. So culturally competent or responsive leaders are committed to something bigger than themselves. At the micro level, culturally competent leaders understand their own cultural identity. They understand their primary and secondary cultural identity groups. They understand their cultural positionality and how that impacts their relationships with others. They understand that our values and cultural experiences shape our attitudes and behaviors about cultural differences. They possess the ability to recognize commonalities and maintain, one of the words that was in our word cloud, openness to differences. They are mediators. They have a willingness to resolve conflict with civility. They are courageous. They are willing to take risks to lead change within their organization, a change that advances behavioral health equity and eliminates discrimination. So thank you all for your participation in that activity. In the words of John Kotter, leaders have two critical characteristics, vision and strategy. Culturally and linguistically competent leaders establish vision, that is a clear, distinct view for the future, and set the strategy, an intentional plan for getting there. One of the first steps in preparing for cultural responsiveness and organizational change is assessing organizational readiness for change. Organizational readiness for change refers to organizational members' commitment to make a change. It's also about self-efficacy, the capability or the confidence of organizational members in their ability to make changes within the organization. So what do these organizational changes look like? They are changes that eliminate barriers and promote effective cross-cultural communication. So for an example, when a staff member encounters a family with limited English proficiency, will that staff member take the extra steps needed to secure an interpreter for a family so that information is conveyed in an understandable manner? Does the staff have knowledge of the language access plan? Has the staff member been trained in how to work effectively with an interpreter? Are there language access processes and structures and policies in place to reduce cultural barriers? These are the type of changes that we're speaking of when we talk about organizational responsiveness. On this slide, we see some sample questions related to organizational readiness for change. An organizational leader may ask, what experience does the organization have in organizational cultural competence reform? What is the history or prevailing attitudes specific to equity-related initiatives in the organization? Are there adequate resources to address cultural competence? Is CLC a part of the budget for professional learning, for workforce development, for language access services? So these are some of the questions that organizations should think about in terms of implementing change within their behavioral health organizations. So I'd like to introduce you to John Kotter's 8-step change model and use this model as a framework for implementing organizational, cultural, and linguistic competency. Dr. John Kotter is an international researcher and author on the topics of leadership and change management, and he is an emeritus professor at Harvard School of Business. Over the decades, he's observed behaviors and outcomes of leaders across various types of organizations when executing organizational changes. He is known for the best-selling books Leading Change and Accelerate It. He has extracted the success factors and created an 8-step process for leading change. His research shows that more than 70% of all major transformation efforts fail because leaders do not use a consistent and holistic approach. The first step of Kotter's change model is creating a sense of urgency. We have 3 images here. One that represents complacency, the second one represents false urgency, and the third one represents a sense of urgency. So when we think about complacency is when organizational members are working at the status quo. Complacency results from believing that the organization is on the leading edge of success without ensuring that it really is. So your organization has developed this non-discrimination statement. It has it posted on its website and throughout the organization. You've done your 15-minute diversity and inclusion training during your new employee general orientation. You're collecting cultural demographic data. You're collecting satisfaction data. And so you're complacent. You've checked the box for organizational, cultural, and linguistic competency. But in addition to having a non-discrimination statement, is there a grievance policy and process in place? Is the statement inclusive of all groups, including the LGBT community, religion, resident status? Is cultural and linguistic competency training a one-time event during general orientation, or is it an ongoing training that discusses important issues related to operations? Is it on your meeting agendas? So these are the type of questions that we have to ask if we want to implement meaningful organizational cultural responsiveness. In addition to collecting demographic information, we should think about, is the organization tracking behavioral health outcomes such as readmissions across various cultural groups, days lost from school, or the number of natural supports. So it's going deeper than just checking our boxes and our 15-minute trainings and so forth. So we want to create systems where we are reviewing the right performance indicators and making sure that we are addressing the needs of our multicultural population. The second is the false sense of urgency, and this may occur when the leader creates frenzy without supporting data. So it's not clear why CLC integration is necessary. Staff just feels like they're just spinning their wheels, and they become frustrated with unrealistic cultural and linguistic competency goals. Where we'd like to be is at a real sense of urgency, the first step of Kotter's change model. When leaders create a real sense of urgency, organizational members are on ready, set, go. When leaders create a sense of urgency, leaders clearly define why CLC is important. They show that CLC reduces communication barriers. It addresses our changing demographics within our patient populations or within our youth, children, and families, as well as within our staff and our executive teams. It's understood that cultural and linguistic competency is important for various commissions such as JCO, the Joint Commission, the Council on Accreditation, the COA, Commission on Accreditation of Rehabilitation Facilities such as CARF. And leaders also convey the sense of urgency because it's important that we know who we're serving. So collecting and tracking cultural data so that we're able to analyze behavioral health utilization patterns and to track disparities. So part of creating a sense of urgency is understanding the why. Why is CLC important? When there's a sense of urgency, leaders have aligned their CLC integration with the mission and vision of the behavioral health organization. And as a result, organizational members are relentless about finding ways to reduce behavioral health disparities. CLC integration is viewed as a win for children, youth, and families, and improving the overall quality of services by the behavioral health organization. So that's the first step, is creating a sense of urgency. The second step is building a guiding coalition. So organizational leaders should find effective, influential, and visible change leaders within their organizations with various levels of expertise, titles, and that are at different levels and within different departments of the organization. So you want to bring together a team, a cadre, this guiding coalition. It could be in the form of a CLC committee. It can also be a part of your governance structure. And so in terms of diversity, we want to ensure that there is diversity across 5 categories. The first is diverse representation of multicultural groups, for example, faith leaders, cultural brokers, community partners across marginalized populations. And it's also important to remember that CLC committees and governance structures should not be code for minority-only groups, but should foster collaborations across groups of people, including majority populations. So diverse multicultural groups is the first level. The second is diversity in terms of systems. So depending on your population of focus, whether it's early learners or juvenile justice, it's important to think about having representation across systems within your CLC committee or governance structure, from child welfare, from the education system, juvenile justice system, behavioral health system, and also primary care systems, because now we're thinking more about collaborative care models and integrative care. Organizational diversity. It's important that we have a 360 perspective of what's happening in our organizations, from the administrative staff to the direct service professionals, peer support professionals, and the executive team. We want youth and family diversity, being true to our system of care core values, including family members from our youth move groups, from our Federation of Family groups, our FRETLA groups, the end consumer, those individuals that are actually receiving the services, having their perspectives is important as well. And then the final level is geographical diversity, including people from various areas of your community to ensure that there are voices from across socioeconomic status levels, so including neighborhood block captains, grassroots leaders, your city council representatives. So you want to make sure that that your guiding coalition is as diverse as possible to ensure diverse viewpoints are represented and to increase knowledge and experience related to various cultural perspectives. Diversity in leadership has been found to be the single most significant predictor of adoption and adherence to national CLAS standards. This may be because support from governance and leadership enables the allocation of resources and services necessary to effectively and efficiently meet the needs of various groups, whether it's religious groups, spiritual groups, cultural groups, mobility, ability differences, and so forth. The third step of Kotter's change model, is form a strategic vision. So linking cultural linguistic competency ideas to an overall vision that people can grasp and easily remember. A clear vision can help everyone understand why you're asking them to do certain culturally responsive behaviors. So for example, you're asking wraparound coordinators to conduct a cultural assessment with all families. Well, explaining why that's so important. It allows our organization to collect accurate cultural demographic data, which allows us to understand who we're serving, understand the cultural values, the cultural preferences, and also ways to integrate those preferences and values into the care plan. So when people see for themselves what you're trying to achieve, then the directives they're given tend to make more sense. So we want to create a vision, but we also want to communicate the vision. We want to convey the vision frequently, powerfully, and embed it in everything that the organizational leader does. Organizational leaders should lead by example. They have to walk the talk and model culturally responsive attitudes and behaviors for their organization members. As Gandhi said, we don't just want to talk about the change, but we want to be the change within our organization. So talk often about the change vision, address people's concerns and apprehensions openly and honestly, and continue to infuse CLC throughout the operations of the organization. The fourth step of Kotter's change model is to enlist a volunteer army. So this step is about raising a large force of organizational members or people who are ready and willing to drive change. And so it's important to use various communication vehicles to drive this change, from newsletters to your staff meetings to your social networking to ensure that you have buy-in from all levels and ongoing buy-in within your organization. The next step is enable action by removing barriers. So it's really important that you remove obstacles to implementing change within the organization. And I can give you an example of this just from an experience with working with the system of care. One of the challenges that we had was that the cultural data on the clinical forms that our wraparound coordinators were using did not match the database fields that the wraparound coordinators were inputting into. So as a result, it became very frustrating for the wraparound coordinators because, it was a task that became, somewhat daunting because what was on the forms was not matching what was in the database system. So we met with our IT team, with our lead wraparound coordinator and evaluation team, and we revised both the forms and database so that there was more congruency between the forms and the database fields. So this improved the accuracy of the data that was being collected, and also it brought us one step closer to standardizing the collection of cultural data. So, so that's just an example of, there was a barrier in terms of collecting cultural data and how, the team came up with a solution to address this issue. Other ways of removing barriers include providing incentives to staff that are involved with cultural competency efforts, recognition of employees for their cultural competency efforts. And then in terms of individuals who may be resisting change, it's finding out the why. Do they need more information about the importance of cultural competency organizational change? Is it adding to their workload in some way? Can we tweak a process so that the change is easier? So these are some of the questions that organizational leaders should think about in terms of implementing change. The next step of Kotter's model is generating short-term wins. So as an organizational leader, it's important to plan for visible performance improvement to keep organizational members committed. And here are just a few examples of wins specific to system of care grants that may be implemented in terms of organizational change. So drafting health disparities impact statements, launching an organizational self-assessment process, creating a CLC plan, creating a standardized process for collecting cultural data about the youth and families that are receiving services. So this is a slide on the Behavioral Health Disparities Impact Statement. It's required of all system of care grantees. And this document should clearly define your populations of focus and also the behavioral health disparities that exist in your community. The second part of this document focuses on specific strategies and activities that will be used to address those disparities. So whether it's collecting data, whether it's looking at outcome measures, whether it's adapting and modifying services or looking at your recruitment and hiring practices, what strategies will your system of care, your organization use in order to address these disparities? And these are things that can be discussed with your CLC committee and your governance board in terms of identifying what those strategies should be. The document should also include how the national CLAS standards that we mentioned earlier will be infused in policies and practices. So the Behavioral Health Disparity Impact Statement is sort of a guiding document, a starting place for understanding who you're serving, understanding your disparities, and some of the strategies that will be used to address those disparities. Right. So we mentioned the CLC organizational self-assessment as a way to generate wins for organizational cultural competency change. And so we'd like for you to participate in a mock CLC organizational self-assessment poll. This poll includes sample questions from an actual cultural competency self-assessment. It's the Cultural Competency Assessment Scale that was developed by the Nathan Klein Institute. So Gary will take us to the poll. Okay, we're going to start with the first question. And so thinking about your behavioral health organization or your system of care, is the idea or philosophy of cultural linguistic competency included in the mission statement of your organization? Yes, no, I don't know. You can select an answer and we'll see what our percentages tell us. Our results show that 75% of our participants on this call said that yes, cultural competency is in our mission statement within our organization, and 25%, one-fourth of our participants said that the idea of or philosophy of CLC, cultural linguistic competence, is in or I'm sorry, that they don't know if it's in the mission statement of their organization. All right. So that's a question that you can go back and address with your governance council or with your CLC committee if you have one. But that's just the starting place, because we know that the mission statement, the vision statement, the core values are the foundation. They're the bedrock of the organization. So it's important that that's conveyed, conveyed to your staff and to your executive teams within your organization. All right, so the second question that's already there, great. Does your organization have a dedicated budget for cultural linguistic competency? You see across the board, we have a third of you said yes. Sorry, still polling. All right, it looks like we have our results here, and so 55.5, almost 66% of you said that your organization does have a dedicated budget for cultural linguistic competency. About 22% of you said that no, you don't have a budget for cultural competency, and 22% said that you don't know. So we know that if it's not in the budget, typically it's not a priority. So it's really important that there are itemized budget line items for such things as interpretation services, translation services, professional development, and workforce development of our teams, of our staff, of our executive leadership. All right, our final question. Does your organization have a CLC committee or internal group that addresses cultural linguistic competency? All right, looks like we have our results here. 80% of our participants today said that yes, we do have a CLC committee or internal group that addresses cultural linguistic responsiveness. And 20% said, I don't know if we have a group. So that's great that we have 80%. And for those who don't know, this is a question that you can take back to your organization. And if you don't have one, then maybe you can start one. So thank you for your participation on the poll. Thanks for your help with that, Gary. So here are some responses from the South Florida Behavioral Health Network to similar questions that you just answered. This is just a snapshot of their organizational self-assessment. The question, CLC was included in the agency's mission statement. Almost 61% of respondents said yes, almost 19% said no, and a little over 20% said I don't know. And you can see here the next one, most people said that they didn't know if their agency had a dedicated budget for CLC activities. So these are really critical questions that you should ask as an organizational leader and as a cultural competency advocate within your organization to ensure that we are providing, quality services and that we have resources in place to meet the needs of our multicultural population. I'd like to share another example of an organizational self-assessment that was done by the Jacksonville System of Care Initiative. They entitled their organizational self-assessment process the Mirror Project because it's an opportunity for behavioral health organizations to reflect on their cultural and linguistic competency strengths, their growing edge, and to develop strategies to improve the quality of services for families that are receiving services. This is the Mirror Project organizational self-assessment process. The process really began with the Cultural Linguistic Competency Committee. The committee decided early on that they wanted to conduct an organizational self-assessment so that they could have some baseline data in terms of where behavioral health organizations were within their system of care. And so several instruments and tools were reviewed. And so the CLC committee decided on the Cultural Competency Assessment Scale, the Nathan Klein Institute tool that I mentioned earlier. And so once the tool was finalized and identified, then the committee began to do education with organizational leaders and even with our youth and family engagement groups, to educate them about the importance of this process in terms of gauging the cultural responsiveness of organizations within the system of care. The survey was then put into a web-based format and administered with 10 behavioral health organizations within a county. There were also focus groups with leadership cadres within each of those behavioral health organizations. The results from those surveys as well as from the focus groups were compiled and then disseminated to each individual organization as well as aggregated for the System of Care Governance Council. And then as a result of the results, recommendations were suggested, and then we began to do work around some of the growing edge areas, some of our areas of weakness in terms of CLC implementation, monitoring, and evaluation. So this is just a snapshot of one of the questions related to understanding who's receiving services, understanding who your populations of focus are. So you can see here there's a pie graph here, and so at level 1, 23% of the respondents that participated in the survey said that yes, we obtained current cultural data. So that's a little under 25% of the respondents. Level 2, the question was asked whether the organization identified prevalent cultural groups so that they really know, what those subcultural groups were, and so 13% said, yes, we do know. So you can see the numbers were pretty low at the baseline level. Identifying language needs, is this a part of your ongoing cultural assessment process? 7% said yes. And then level 4 was had identified a community of focus. So understanding generally who was being served within the community, understanding what geographical area was targeted for their system of care grant or for their behavioral health organization. So as a result of the data that was received through the organizational self-assessment, these are some of the changes that were made within the system of care. So one of them was to update the clinical database to include standardized cultural demographic information. There were policies developed to conduct a cultural discovery assessment with all youth and families receiving services, and also making sure that cultural considerations were added to the care plan. This was actually a change not only in terms of policy, but also a change in form. So cultural considerations were added to the care plan, and also a cultural assessment was identified to be used by all the wraparound coordinators. A training assessment was conducted. A training plan was developed as a result of that assessment, and then CLC trainings were prioritized in terms of educating providers about cultural issues within the system of care. Tracking of satisfaction data, there were policies related to that, and then also tracking of behavioral health outcomes. So specifically identifying what are the behavioral health outcomes that we're going to analyze on a quarterly basis across cultural groups. And here are some of the examples of that, looking at readmissions related to suicidal ideations, days lost from school, and also looking at, has wraparound really increased natural support as a result of that care coordination process. Okay. So those were just some examples of wins, generating wins so that your organization sees the value of cultural competency work. So the last two steps of Kotter's model are don't let up and sustain acceleration, and to make it stick. So in terms of acceleration or sustaining acceleration, an example of this is, continuing, your CLC trainings. Again, it should not just be that, general orientation, but ongoing training about cultural issues that may arise when working with families. Along with other system of care core values as well, being family-driven and youth-guided, making sure that's at the forefront of meetings and on agendas and so forth. So sustaining the work and keeping cultural competency at the forefront of the work, because it is really about quality services. And then the last step is make it stick. And so we make it stick by making sure that we have written policies and processes in place. So, we can't just sit in meetings and talk about implementing cultural competency, but we should have written, specific policies across our workforce development in terms of training, how often we're training, sample topics of what should be covered, in terms of communication, our language access plan, and then even with our continuous quality improvement, what are those indicators that we'll be reviewing, what's going to be on our dashboard in terms of tracking these disparities and measuring our success in meeting the needs of marginalized populations. So those are the 8 steps of Kotter's model. And are there any questions for me regarding organizational cultural competency? One thing I'd like to emphasize is that oftentimes when we think of organizational leadership, we think of people that are in executive positions, but we are the leaders that we are looking for. And so you don't always have to have the title of CEO or Continuous Quality Improvement Director or Director of Human Resources to be a cultural competency change agent. So we all have the capacity to be cultural competency catalysts for change. And so this is important work. This is part of our mission, and it's also a part of federal mandates in terms of the national CLAS standards in meeting the needs of diverse groups. So thank you for your attention, and I welcome any questions. You can type them in the I see a comment about cultural competency plans and policies. We do have some samples that we can send you. We also have a CLC library, library that's based at the USF website as well. And it is listed in our resources section. So there are resources that are part of this PowerPoint. Any other comments? Thank you for your comment, Joyce. I'm glad it was a great refresher. And also in the resources, there is a link to the Cultural Competency Assessment Scale that I mentioned. There's also an article on the work of leadership by Lori and Heifetz. And there are also some documents on health equity and leadership as well. So make sure you take a look at the resources that may be helpful in terms of developing your CLC plans and also just implementing organizational cultural responsiveness. If there aren't any other questions or comments, we're going to go ahead and close the call. We thank you for your participation today. We encourage you to move forward in terms of implementing those national CLAS standards, which is our blueprint for implementing cultural linguistic competency. And we look forward to our next webinar. Thank you.